Okay, welcome and thank you for joining us today for the meeting of the New York City Health and Hospitals Board of Directors. Today's meeting is officially called to order. Please note for the record that Erin Kelly is representing Deputy Mayor Ann Williams Ison in a voting capacity. Next on the agenda is the adoption of the minutes for the board meeting held April 28th, 2022. Are there any questions, comments, or suggested changes? Can I hear a motion to accept the minutes? So let me ask for your vote one by one. Dr. Katz?
Yes.
Dr. Calamia?
Yes.
Dr. Marton?
Yes.
Dr. McRae?
Yes.
Gary Jenkins? Erin Kelly?
Yes.
Robert Nolan?
Yes.
Frida Wang?
Yes.
Sally Hernandez Piñero?
Yes.
And Anita Kawatra?
Yes.
Thank you so much. The minutes have been approved. During the executive session, the board received and approved oral and written governing body submissions from NYC, HN, Kobe, and North Central Bronx. The board received and approved the 2021 Performance Improvement Plan and Evaluation written submission from Gouverneur Diagnostic and Treatment Center, Gotham and Rehabilitation Center. The board also received and approved semi-annual governing body reports. It's a written report, pre-submissions from NYC Health and Hospitals Harlem. Also, please be aware the fiscal year 2022 annual public meeting for the Borough of Brooklyn is scheduled for June 14th, starting at 6 p.m., and this meeting will convene virtually. Next on the agenda is Vendex approvals. Since we began the process of approving contracts prior to Vendex approvals, there are 18 items on today's agenda requiring Vendex approval, of which 11 have the approval. There are 11 items from previous board meetings pending Vendex approval. Since we last met, no approvals were received. We will continue to notify the board as outstanding Vendex approvals are received. So I'm going to move on now to the resolution. So let me begin with item number 2. Dr. Calamia, you want to read it?
Sure. Thank you. So authorizing New York City Health and Hospitals Corporation, the system, to negotiate and execute an extension of its affiliation agreement with the State University of New York Health Sciences Center at Brooklyn, also known as Downstate Health Sciences University, SUNY, for services at New York City Health and Hospitals, Kings County, and New York City Health and Hospitals, Coney Island. The affiliation agreement would be through December 31st, 2023, and the total amount would not exceed $13,310,191, and that's inclusive of a 10% contingency fee. This resolution is being presented directly to the board as a whole.
Thank you, Dr. Calamia.
Hi, and I'm Andy Cohen, as you know, SVP and General Counsel. I'm here with my colleague, Deb Brown, who has also worked on this contract and extension. And on the phone, I think we have a representative from our finance department in Matt Fay who will be able to address or answer any finance-related questions. So, and I am filling in for Michelle Allen, our Chief Medical Officer, who is, of course, lead on these affiliation agreements, but has not been able to get here quite yet today. And also, we have at the table the CEO of Kings County Hospital Center, which is the primary the primary facility that uses the services of SUNY Downstate, Sheldon McLeod. Thanks, Sheldon, for being here. So on the first slide, am I controlling the slides? No. This is just a history of recent contract activity with SUNY. You'll notice, and the extensions that we have provided. This is a longstanding relationship with SUNY. You will see the interesting thing about this slide really just shows that we are always at least a year away from the actual termination date of any contract when we re-up it and extend it for a period. This is for a very specific set of reasons relating to SUNY's union contracts. When we intend to extend the contract, we don't want to put them in a position of having to provide notice to providers that they would be required to provide if we didn't actually have an extension of the contract more than a year in advance of the termination of the contract. So this contract that we are in right now does not terminate until the end of next June, but we are extending it so that we don't bump into the 1 year, into a 1 year period before the end of that termination. So we are here seeking an additional 6 months to renegotiate and do a longer term extension of this contract with SUNY. Next slide. So these are the amounts that have been spent per year on the SUNY contract. You will see that, starting back in FY 2020, we've been in the range of just over about $21 million, and expect to be in that same range of spending along with a contingency for the additional 6 months that we are seeking. We're seeking a $12 million authorization to spend for the next 6 months. Matt Fay, if there's anything you want to add on this slide.
Andy, really nothing specific to add other than this is a very stable affiliate. Our spend year over year changes by roughly 1%. We anticipate that will be the continued trajectory through 23 into the first half of 24. And
of course, our contingencies have to do with things like potential COVID or other kinds of surges where an anticipation of additional actual clinical services might be needed. But we hope and anticipate that we will not need to use that contingency. So the reason for the extension, as I mentioned, is that SUNY Downstate's union contract requires it to provide 1 year's notice of termination to its employed physicians. The current agreement expires at the end of June 2023. This 6-month extension will allow the following services to continue without disruption while the parties negotiate a new longer-term contract or contracts. That is the provision of contract services providers at New York City Health and Hospitals, Kings County, in emergency medicine, psychiatry, and oncology. Those are the departments that they provide staffing for. And at New York City Health and Hospitals, Coney Island, there are a few contract services providers in surgery. So simply, the request here is for authorization for to spend a not to exceed amount of $13,310,191 on a 6-month extension of this contract while we work on negotiation for a longer term contract or contracts with SUNY.
Thank you. Thank you so much, Andy. So any questions from board members?
Jose, I have a question.
Please, Rita Wang, go ahead.
Thank you. Thanks, Andy and Matt. I do have a question on the costs because I'm a little bit confused at the growth or the escalation. So the chart that was on the history of the cost by fiscal year, those amounts that we're showing in the prior years were the actual amounts spent. Is that right?
That is correct.
Okay. And then the proposed FY24 6 months is what we're approving now. But I think if you and I think you mentioned this, Matt, that it's a 1% increase per year, but the 12 million for the 6 months would be a 10% increase from last year, or I guess this year from fiscal 23. So I'm wondering what's going on in our expectations for costs, et cetera, that would be such a high increase. Because then we have the 10% additional contingency on top of that.
Yeah, you are correct. So Frida, I think it's a good question. And I think the intention on our part was to maintain the 1% and then to have the 10% contingency on top of that. Then a couple of focused salary adjustments that would impact this particular contract, but not to the tune of 10%.
So is the not to exceed then a little too high? Can we take that amount down, or because I think we're at a 20% increase basically now with the contingency.
Yeah, we could take that down. We could take that down to 11,110,000, which would keep it in line with the 1% increase that we've seen historically.
And then add a 10% contingency to that.
And then add a 10% contingency on top of that.
Okay. So Andy, does that mean we need to just make a technical amendment to the resolution?
Yeah, and I'm wondering, hi, Michelle, who's just joined us in the room. I am wondering, Matt, I think we need some precise figures and then we can make the amendment. I'm not sure I have the precise figures right now. Do you have them, Matt, right now?
I do. So we can follow the same logic that we had used previously, which was the application of a 1% annual increase to the base spend. What that would do, and Frida's correct, right? We looked at the 1% year over year, and then I think applied the 10% early in the calculations. Frida, I apologize for that, and eagle eyes on your part. So Andy, I would feel comfortable with us looking at the 11,110,159 as the base. We'll have to do a quick calculation between the two, Kings and Coney, and then add the 10% to the 11,110,000 base.
Okay, so Jose, can I make a suggestion? Might we table this for just a few minutes, do a couple of other items, and then just come in and do the an amendment, a formal amendment on this with the right numbers?
Yes,
Is that okay?
let me ask a quick question on it then. The 1% was included the salary adjustments that you mentioned? The slight salary adjustments, that's what it was? The 1%?
Yeah. The 1% does account for the salary adjustments that we're seeing year over year, and also takes into account the kind of ongoing reduction of SUNY staff as we transition that relationship at Kings County more to PAGNY.
Okay. So let me then, are there any other questions from board members on this issue? So let me then table it for a few minutes while we do some calculations, and then I'll bring it back, the vote back. So let me move on then to resolution number 3. Ms. Wang, Frida?
Okay. So the resolution, sorry, I just need to pull it up, is authorizing the New York City Health and Hospitals Corporation, the system, to execute 3-year agreements with each of the 17 law firms listed in Annex A attached, the med mal firms, for defending the system in medical malpractice cases on an as-needed basis, with the system holding 2 one-year options to renew for an amount not to exceed $86 million over the entire potential 5-year term. This resolution was presented and discussed at Finance Committee on May 9th and was approved to bring forward to the whole board. There was a proviso that the team will present some additional information that I think they're prepared to talk about, and I will turn it over to, is Mr. Chung going to walk through the presentation?
Yes, thank you very much.
Great, thank you.
Good afternoon, everyone. The Office of Legal Affairs.
David, yeah.
Good afternoon, everyone. My name is David Chung with the Office of Legal Affairs, Claims and Litigation. The Office of Legal Affairs relies on a mix of both in-house attorneys and outside counsel law firms to defend the system against medical malpractice claims. We handle about 1,600 matters which are open and active at any given time. And the use of outside counsel law firms is actually a very common thing for hospital systems such as ours. However, New York City Health and Hospitals is unique in that it also has a team of in-house litigators. The cases that are sent and assigned to outside counsel typically are the most complex cases, highly specialized cases, and cases that have the highest exposure dollar-wise. And in the context of medical malpractice litigation, what we are seeing is a trend towards rising jury awards and also changes in the law that are favorable to plaintiffs. However, we've been very fortunate in keeping the cost of medical malpractice claims or payouts from rising over the years. And this is actually quite a challenge to do because the plaintiff's bar is constantly pushing for changes that are favorable to plaintiffs that can have a significant cost against hospital systems such as ours, including a bill that is currently pending in Albany now called the wrongful death bill, which can substantially change the kinds of damages that can be awarded in a wrongful death claim. So going back to what the Office of Legal Affairs has been doing in terms of managing costs. Just the prior slide, please. The previous slide, please. Medical malpractice payouts, H&H paid approximately $195 million in fiscal year 2003. And the last bullet point here is what we wanted to compare it to in terms of using effective use of outside counsel law firms has helped us manage the cost, and we've been able to maintain it between $108 and $136 million between fiscal year 2012 through 2020. We didn't include fiscal year 21 in that data set because of a slowdown in the court system due to COVID, but we closed the fiscal year at $87 million. Next slide, please. So the outside counsel expenses historically has been roughly $14 million every year, and those expenses are completely funded by the City of New York. Currently, we have 11 law firms on our panel for our outside counsel panel. This is based on an RFP that was completed in 2017. As a result of that RFP, contracts were awarded to 12 law firms, which initially had a 3-year period, which expired in February 2021. And at that time, we extended those contracts for 2 years through February 2023. We currently only have 11 law firms on our panel because one of those panel firms closed operations during the pandemic. So in this past year, we released a new RFP because what we started to see was that experienced partners in some of the firms became more routinely declining our cases. And we saw that the staffing quality dedicated to our account started to decline. And what we were able to determine was this was due to the fact that the rates which were set in the 2017 contracts were substantially below market. And that was coupled with the pressures that the law firms were having in terms of recruiting and retaining attorneys for our account. So in the new RFP, we didn't unilaterally set rates. We asked the firms to propose rates that made sense for them, which we would negotiate. And so the two goals we had here were to address the rates and also to increase the panel or the number of law firms that would be available to provide the services that New York City Health and Hospitals would need going forward. So the estimated costs of outside counsel expenses would increase about 20% based on the negotiated rates in the new RFP. Next slide, please. So with respect to, as an overview of the procurement process, on February 8th, our contracting division published the RFP publicly on the city record, and also sent directly to the RFP to 28 potential vendors. And any vendor responding to the RFP had the option of being considered full service. if they were able to propose, if they were able to provide a full array of the services one would normally expect from a medical malpractice full service firm, or they could identify the areas of expertise and be considered specialty. We had a pre-proposal conference on February 17th, which was attended by 24 vendors. A deadline was set for March 4th for proposals. Each of the 24 potential vendors, submitted proposals, and the evaluation committee conducted selected vendor interviews on March 28th and 29th, and on a weekly basis between March 11th and April 5th, conducted weekly meetings, and on April 6th, completed the scoring of all the proposals and identified 17 law firms that had the best scores to recommend to this board. 13 of those firms were considered full service, and 4 of them were specialty. Next slide, please. With respect to eligibility and evaluation criteria, the RFP included minimum criteria, which are the 6 categories you see on the slide. Those categories included appropriate licensing for attorneys, the law firm being in business for at least 3 years, having an office in New York State, agreeing not to represent plaintiffs in medical malpractice suits against health and hospitals or the city of New York during the duration of the contract, $5 million of professional liability insurance, and additionally, the lead partner on the account, managing our account, would have 15 years of verifiable medical malpractice defense experience. The evaluation committee also specifically looked at different categories for scoring. There are 4 of them. Those included subject matter expertise and the use of best practices in handling claims, the law firm's experience, organization, and resources, including the resources the firm had, which was they were willing to dedicate to our account. And with respect to experience, they looked specifically for verdicts, trial experience, and verdicts on behalf of their clients. They looked at technical qualifications for full service firms, as well as previous client references and the performance of the firms that were currently on our account. And lastly, they looked at the cost proposals submitted to the as part of the RFP. Among the 17 firms that were selected, 8 of them are currently on our panel, and 9 of them would be new if the board approves this application. Next slide, please. With respect to MWBE, the diversity team determined that under Operating Procedure 100-10, medical malpractice legal services in this RFP would be exempt from the MWBE program because the services that are being requested had to be performed by uniquely qualified individuals. However, in order to ensure that we didn't miss any MWBE opportunities, they looked at the market to analyze, to determine whether there were any MWBE firms that would be able to provide the services requested under the RFP, as well as meet the minimum criteria for participation. A diligent search was conducted, which we will describe in the next slide. But a review and an analysis of that search revealed that there were no MWBE firms providing the services requested, and also which also met the minimum criteria for participation. And of note was that the RFP was publicly posted, and no MWBE certified firm submitted a proposal. Next slide, please. So, as part of their search, the diversity team searched various directories, which are listed on the slide, as well as a general internet search. The directories include New York City, New York State, the National Minority Supplier Development Council, and the Women's Business Enterprise National Council. So after conducting a search of all those directories, as well as an internet search, the diversity team identified 7 potential businesses. However, when they took a close look at those businesses, which included looking at the website in terms of the services that they described that they were providing, and specifically the bios of each partner of those firms, as well as looking at the court records in terms of what they had filed with the court system. And after analyzing the results of the search, they determined that none of those 7 businesses met the criteria for participation. And again, they noted that the RFP was publicly posted and no MWBE firm responded. Next
I
slide,
would
please.
want to interrupt you for just a second, if you go back to this, just to hang on the slide for a minute.
Sure.
Because it was an area that I think many of us found surprising. After all, among the SVPs, 2 of the lawyers are women. The lawyer giving the presentation is, I'm sorry, thank you, is Asian. How could it be that there are no law firms that would fit this? One of the things that we learned, besides the points that David has already made, is that there are a number of medical malpractice lawyers and law firms who represent plaintiffs. And that it's easy for me to understand and may even be related to the fact that they're women or come from underrepresented groups, that they wanted to be representing the person who many people might feel to be the harmed person. And that also causes confusion, because if you just ask yourself the question of minority or women-owned malpractice lawyers, but you don't include but they have to be wanting to do work for the institution, not for the plaintiff. And you'll understand also that most lawyers need to specialize in one or the other, because hospitals are not going to hire lawyers who are simultaneously suing them. It just creates too much of a conflict of interest. So I feel like it's an unusual field in that you're getting people who have to be one or the other. They can't be both, even though, from their training, they could be both, right? I mean, they went to the same law school, they graduated, they were interested in malpractice, but in terms of practicing, they're going to have to choose one side or the other. And even a cursory review of firms shows, yes, there are MWBE plaintiffs' lawyers, but not ones who want to do institutions. And I think that's created some kinds of confusion if you're not very focused. And it's implicit in what David is saying, did not meet the minimum criteria. But again, I want to emphasize it because so many of us, when we heard this, thinking of the great women lawyers we knew, the great minority lawyers we knew, were sort of surprised at this outcome. Go ahead, David.
Thank you for that. Thank you. Next slide, please. So as part of the RFP process, our diversity team asked the 17 firms for information and gathered some information regarding their workforce diversity. The result of that is reflected in the slide number 8. So our diversity team prepared this EEO summary to give this board an idea of the workforce diversity of each of the firms. But I would note and point out to the board that only the first 2 firms had more than 150 employees, which is why you see on the last column, EEO determination approved. And all the other firms didn't have a sufficient number of employees for them to conduct an appropriate statistical analysis. Okay, so the next slide, if everyone is ready to go on to the next slide, because I saw some people looking at the slide, is that we're here today to request approval from the board to award contracts to the 17 firms listed here to represent New York City Health and Hospitals in in complex medical malpractice cases. The 17 firms are listed here. The asterisk next to each firm denotes a firm that is currently on our panel. I'll point out that 3 of the 11 firms were not included, did not receive the highest score, so they are not included here. The request is approval for in a not to exceed amount of $86 million. That would be for a 5-year period with an anticipated start date of July of 2022. That would be a 3-year contract with an option to renew for 2 additional years. The contract would allow H&H to terminate for convenience, and of course, would not guarantee work to any of the firms that are awarded a contract. Thank you.
Thank you, David. So let me go through board members, seeing if they have questions. Dr. Katz,
No.
Dr. Calamia.
Yeah, thank you, Jose. I mean, one question I would have is that the impetus for this was in part the fact that perhaps our rates were not high enough, and in fact, we were being turned down on some cases. And so my question is, now that we're looking at rates which we think are more industry standard, do we have some clause in our contract that has some, I guess, obligation on the part of the legal services to, in fact, take cases that we think they're most appropriate for? Because I think the issue of turning down was bothersome to me. So if you could really address that, that would be helpful.
Absolutely. So Dr. Calamia, one thing to just point out is that it is, we have a large panel for a reason, and that is because certain firms are very specialized and very good at certain things and not other things. Others specialize with, get to know certain facilities and work more closely in those facilities. We found that that has been a positive strategy. But it's also because it is not unusual for a variety of reasons for firms to decline a particular case for reasons that we see as totally legitimate and in some cases required. For example, sometimes we're a joint defendant with another hospital and these firms have business with other hospitals and there may be a conflict. They're required to flag that and address that, often by declining a case. Sometimes their workload, these cases come in at not necessarily expected times and rates. They might be on trial at the same time that we need some intense work. So it is very, very normal for there to be declining. What we saw was a little bit more of that because the firms were not able to retain their people and hire appropriately. They said some of those reasons were associated with economics and rates and the fact that talent was more expensive. And we also had a few firms who we found that the declining was a little bit less cooperative. It was less based on reasons that we could understand, like they lost a number of lawyers and were not able to hire quickly enough to staff our work, but for reasons that seemed like we were not as high of a priority. We were really trying to address expanding our panel so that we had more choices, as well as making sure that those firms that were trying but not really able to have people, not able to have the staff that they needed, would have the resources to do so. It's not possible for us to say you must take our cases, but by having a larger panel, because for the reasons that I described, it would be appropriate or normal in the industry. But for the reasons that I described, having a larger panel where we have more choices, all of these firms are in business for a reason because they want business. We feel like with the more typical rates and the larger panel, we do not anticipate having this problem. Again, it is always possible. in any industry, rates can shoot up. It happens in compensation, it happens in other areas, and in that case, it is possible we'd have to come back to this board at some point a little bit before the 5 years are over and say we have to address that. But at this point in time, we don't anticipate it. And really, it was very unusual for us to have set rates in the past, and we don't do that for most other services at all. And so we think by doing a more market rate, we reduce the risk of this happening again very substantially.
I would just add, as a non-lawyer, I don't know that I'd want someone who didn't want the case defending us.
Yeah.
I mean, I think that's part of the implicit in not saying you must take this case. I mean, these are, I'm sorry, yeah. I mean, it's not easy, right? We talked also about, how do you measure performance? It's not easy to objectively measure performance because there are no parallel universes. Each of these cases is fairly individual. And what you want is a lawyer who wants the work and who, really believes in the case and who's going to do the best job. And so I don't see how, if we said, if this is in your area, you must take it, I guess I would worry about whether or not they would really do their best job.
Yeah, Mitch, I understand that, and I totally agree with that. And yes, the last thing you want is someone who's not happily or willingly, defending the issue. But I think the sense I'm getting, though, is that there was, and I don't know if it was across the board or if there were some firms more than others, but if specifically things were turned down because they felt that there wasn't sufficient funding, I think, we need to know, because that firm in particular, those firms, that is a performance issue for me. I mean, if they are often turning down, not because, again, of conflict of interest
Sure.
and not because of lack of expertise, but purely on a economic basis, that would concern me. And I agree, I understand fully. We cannot put into a contract, you must take a case, because as you said, there are many examples where that's just not, it's not possible. But I do think we need to keep a close eye on that. And I think we should get a sense early, not late, and get a sense, is it many? Is it a few? Is it our most, I guess, reliable ones with respect to good defense that are the ones who are having issues? So those are the types of things I think just want a little bit more of a kind of a robust, sort of oversight of. But I appreciate that, and I appreciate the answers given. I do get it. Just one other question. I'm sorry, I don't want to monopolize here, but the other question I have is: there's mention that we have managed to hold the line fairly well despite a climate of much higher amounts that have been awarded. And I guess question A: is there a reason, do we think, on our part that's been helped, that we managed to encourage that? Is that in part because of the law firms? Is in part something we do internally to try to help? And part of that then would be do we have educational process? Are there, proactive things we do to try to minimize, our malpractice exposure?
So I'll start. I mean, because I just did 2 weeks ago my CME specifically for health and hospitals on lowering our malpractice costs. And I did, I think, 6 units for my practice. And they were all, actually, I thought they were quite good, but they were all tailored about documentation, and every doctor in our system is required to do them. So we do them. I mean, I can't, and maybe David or will have a better answer, or Andy. What I've read is that one of the things that most affects awards is whether people believe that the doctors did their best and communicated with their patients. And one of the things that's different about health and hospitals than a lot of medicine is that our doctors are salaried and they're not doing things in order to make money as individuals. And that I would hope that translates to patients feeling like we did our best. And they always say again that that people sue doctors who they feel did not try, and that's the number one reason people sue doctors.
David, anything you want to add? If I may, because David won't say it about himself, I do think it's very hard to tease out what is a matter of actual, performance in the healthcare system versus legal support. We do know that there's not a perfect one-to-one correlation between med-mal payouts and actual quality of care provided. Some people don't have legitimate claims, and nonetheless result in a settlement or a payout, and vice versa. Some people may have legitimate claims and they never go to court. So it's not a one-to-one correlation. This unit of legal affairs is managed by David and team extremely tightly. They handle cases quickly. They are often turned to by the judiciary and committees for advice and kind of recognized as a strong team. I will just say that. So I do want to say, I do think that there has been really focused attention by David and his leadership team on making that unit work as closely and effectively with doctors and risk management in our system. It is very much a multidisciplinary team that makes these things go. And they're very strategic and hold law firms' feet to the fire also, I will say, very, very closely. It is unusual for a system to have such a significant internal team. We use that team to make sure that we are getting the very best out of our vendors, as well as handling some of our own cases. David, anything you want to add?
No, after that, I have nothing to add.
Thank you, David. So I'm going to move on, Dr. Martone. Dr. McRae?
No question.
Thank you. Dr. McRae? Gary Jenkins?
Yes.
Erin Kelly? Robert Nolan?
No question.
Thank you.
Aye.
Frida Wang?
No more questions, thank you.
Sally Hernandez Pinheiro?
I just want to go a little bit further. Oh. I just want to go a little bit further at the question of increase in fees and the reasons for that and the MWBE issue. So I'll start with the question of fees. You had an average of $14 million, which I think is not very meaningful other than as a mathematical formula, because obviously the changes in cost have been dramatic. But I'd be curious to know, if you know, how much the contract that we'd originally approved, which we're now replacing with this contract, how much was that for, and how much was the contract before that for?
So $14 million actually, I don't think, was not the actual amount of the contract. $14 million is a subsidy that is provided to us annually by the city of New York to cover, because the city used to defend us, and by an MOU, we brought the services in-house.
Okay.
The city still pays the cost. So that's what the $14 million is. I do not think that I have, and I don't know if you have, David, actual data on exact costs over the last few years versus what we anticipate. And of course, the cost is a function of rates times amount of hours or amount of work.
That's what I was going to say.
Yeah.
You pointed out that we've decreased settlements, but part of that may be as a result of increasing hours.
Correct.
Kind of more aggressively litigating.
Correct.
To reduce your settlement costs, unless you're in the Bronx, in which case we're going to lose. But the question of MWBE, so we found 7 firms. We said that they didn't meet the minimum requirements. We talked about, Dr. Katz mentioned that some of them may indeed be representing plaintiffs, and I think it is the case that you'll find more MWBs doing plaintiff work because it's contingent, it's faster. I mean, there are all kinds of reasons why it's more appealing. But of the criteria that we have listed here, the 6, is there one or more that was the disqualifier for the 7 firms? Putting aside if you represented, you refused to represent only the institution.
Sally, I think, and David just confirmed, but I think the answer is it was almost, for almost all of them, we sort of stopped at the verifiable number of years of doing medical malpractice defense.
Okay,
In
and
other-
that what, that's,
which is basically the substantive, really it is the substantive criteria that to do this work for us, you need to have a lead partner who has at least 15 years. And when we
Right.
say verifiable
yeah,
experience, what that means is that like you haven't just taken a deposition in the space, but that you have taken cases to trial and to verdict. Is
okay, so it is the 15-year.
that right, David? I think that was almost all of it.
That's what I would
Right.
have
Yeah.
imagined.
And
would be
maybe
the case.
for the non-lawyers, I mean, I think it's also relevant that part of why at least as I would understand it, we've set the bar so high is because David runs a great unit, right? So if let's say we didn't have an internal unit
Right.
that took cases, then you would need a whole range, right? Because you'd have some easy cases
Right.
and some hard cases. But because David has a great unit and they do most of the cases, then the cases we're going out for are only the ones that are incredibly complicated or specialized.
Right,
And right, I think if we were going out for bid without David's unit, if we didn't
Right.
have it like many hospitals, we would need more of a variety.
Right.
You wouldn't want to pay
Yeah.
right the most specialized
Right.
lawyers, right?
Right,
You
right.
would need some very general lawyers.
okay.
Exactly right.
Those are my questions, thank you.
Thank you so much. Anita Kawatra, any questions?
No questions, thank you.
Thank you. Then let me ask for a vote. Dr. Katz?
Yes.
Dr. Calamia?
Yes.
Dr. Martone?
Yes.
Dr. McRae?
Yes.
Gary Jenkins? Aaron Kelly? Robert Nolan?
Yes.
Frida Wang?
Yes.
Sally Hernandez Piñero?
Yes?
Anita Kawatra?
Yes.
Okay, thank you. So thank you so much for the
Thank you very
presentation,
much.
David. And
Thank you.
Jose Pagan, yes? Okay, let me move to the next one. And then we'll leave the other one.
Okay,
with
and
you.
we're getting a revised resolution in just a moment.
So the next one is number 4, Fenioski. I'll read that one. He's not in the meeting now, but so authorizing the New York City Health and Hospitals Corporation, the system, to execute a 5-year revocable license agreement with the Federal Bureau of Investigation of the U.S. Department of Justice, the licensee, for its continued use and occupancy of 150 square feet of space on the roof of the main building and the 14th floor mechanical room to house communications equipment at Coney Island Hospital, the facility, at an annual occupancy fee of $10,466 or $69.77 per square foot, to be escalated by 3% per year for a 5-year total of $55,564. And this was presented to the Capital Committee on May 9th, 2022.
Next slide, please. The Federal Bureau of Investigation has been operating communications equipment at Coney Island Hospital since 2002. This equipment is a VHF FM radio equipment that's conventional public safety two-way radio equipment to enhance performance of its communication systems. The equipment does not compromise facility operations and patient safety. Next slide, please. In September 2017, the board authorized a 5-year license agreement with the FBI for its continued use and occupancy of 150 square feet of space on the roof in the main building of Coney Island Hospital and a 14th-floor mechanical room for the operation of this system. The agreement had also been approved twice before, in 2007 and 2012. The current agreement expires September 30th, 2022. Next slide, please. The agreement terms are as follows. The FBI will continue to occupy the space as previously described, 150 square feet on the roof and of the main building and a 14th-floor mechanical room. The occupancy fee, as stated earlier, will be $10,466 per year, or $69.77 per square foot, escalated at 3% per year over a 5-year term for a total of $55,564. This is a 3% increase over the current fee. This is a unique situation that where it's a little bit difficult to get a fair market analysis, and which is also makes it a little bit less significant. That's it.
Okay, thank you so much. Any questions from board members on this one? Okay, hearing none, then let me go ask for a vote. Dr. Katz?
Yes.
Dr. Calamia?
Yes.
Dr. Martone?
Yes.
Dr. McRae?
Yes.
Gary Jenkins? Erin Kelly?
Yes.
Robert Nolan?
Yes.
Frida Wang?
Yes.
Sally Hernandez Piñero? Anita Kawatra? And Jose Pagan, yes. So resolution passes. Let's move to the next one. It's authorizing New York City, it's number 5 on the agenda, authorizing New York City Health and Hospitals Corporation, the system, to increase the funding of its contract with Consigli Construction Company, Inc., to serve as construction manager under a guaranteed maximum price structure for the construction management of the system's Outposted Therapeutic Housing Unit project at NYC Health and Hospitals Bellevue from the $120,918,083 approved by the board in November 2021, based on a contract price of $109,925,530 and a 10% project contingency, to $127,581,541, which, when added to a 10% contingency of $12,758,154, yields a cost not to exceed of $140,339,695. And this was presented to the Capital Committee on May 9th, 2022. And Fenioski Peña Mora recuses himself from it. He's not in the meeting now, but so.
Okay, thank you, Mr. Chairman. My name is Oscar Gonzalez, Senior Assistant Vice President of OFD, and with me is Aaron Anderson, Assistant Vice President of the Correctional Health Services, and we're here to request for an increase in funding for the Bellevue Outposted Therapeutic Housing Units, also known as OTXHU, associated with the SCOC, State Commission of Corrections, which is a change to the Consigli contract for the Bellevue project, which is a CM build with a guaranteed maximum price GMP. So Aaron's going to provide a little bit of a background, and I'm going to go back into the procurement and some of the history there.
Yeah, thanks, Oscar. Good afternoon, everyone. Just a quick refresher on the Outposted project. I mean, this is about safely and humanely increasing access to specialty services for our most vulnerable patients, bridges the gap between, inpatient hospitalization and what's provided in the jails. It's a pioneering approach that really meets the healthcare needs of our patients in a more humane way. CHS determines admission to and discharge from these units. Next slide, please. Next slide, please. Anyway, while waiting for the next slide, so the number of benefits to this project. This is really about creating a therapeutic and more normalized environment for our patients. It's about safe access to specialty and subspecialty services, and really improving continuity of care between CHS and the rest of the system, but also providers in inpatient, outpatient, and our outposted services. Importantly for the facilities, this is a capital infusion for the prerequisite infrastructure improvements that have to happen with city dollars. So we're very excited. Oscar.
Thank you, Aaron. So a little bit of history, more history. The project was publicly announced by the mayor in November 2019, which gave us the green light to proceed with the work. Obviously, COVID hit right around 2020, so it was pretty busy times, but regardless, we pushed ahead with the procurement, and we were able to start designs both at Bellevue and Woodhall, and those contracts were approved by the board in June of 2020. That would be a design consultant, Array as the design consultant, ACOM as program manager, and E4H as the design services for the enabling portion of the Woodhall project. somewhere along the line, we did get a request to increase and accelerate the project and try and get the project completed by the end of 2022, December 2022. So we proceeded with the procurement right away, found the contractor, Consigli, for CMGMP, and we brought that to the board in November 2021, which we got board approval. All along, we were working with SCOC and trying to secure the final regulations on the project. The idea of the GMP was to buy out the majority of the contract, but not necessarily the entire contract. We knew enough of the components, what we needed, the clinical areas, circulation space, the outdoor space. So we knew what we needed to design, and that's what we designed too. But as we finished up the design and got all the regulatory approvals, we were going to lock in the final price. In January, so this is the reason for the amendment, in January 2022, New York State Commission of Corrections, SCOC, required that we have a new location for the outdoor space. So originally, we were planning for the outdoor space to be on the top of the H building at Bellevue Hospital. So we had to quickly pivot and redesign and create a construction approach for recreation, patients, and staff flow, and obviously the program floor plan. So there was a lot of juggling between designers, the regulatory. Long story short, by March 19th, we were able to present and get SCOC approval on the new design, and then we started negotiating with Consigli, and we locked in the price on April 7th for the now additional scope for the new location. So the good news is that we're still going to do the project under 13 months. The bad news is that now we were starting late, which means now we were going to finish a little bit later. So the new substantial completion date now was March 2023, which is 4 months after originally planned. The next will show you the structure, which is Health and Hospitals, OFD, and CHS together overseeing the project, which is managed by AECOM. And there's the 3 components to it. Array is doing the design services both at Bellevue and Woodhall. At Woodhall, we're doing the design services from E4H for the decanting portion, where Hunter Roberts is the CM and Gemco is the general contractor. But back at Bellevue, Consigli is the the builder, which holds the CM build GMP contract. The next slide will show you what we're trying to do. So essentially, we're looking at 110 patient beds, dedicated medical, mental, substance abuse units. So it's essentially your clinical space, circulation, core, admin spaces, and all the infrastructure, mechanical, electrical, plumbing system that gets incorporated. So of the H building, the second floor gets the programming space. Originally, we we're going to have the outdoor space on top of the H building, but now from that picture that you see, we are creating where it says elevation there, we're creating a elevator shaft. That's where the clients get dropped off, goes up the shaft into the Sally Port. We're creating a bridge that goes over the emergency department into what's now the outdoor space. So it's very complicated, but it is it meets the SCOC requirements. It meets the programming requirements. It does cost more. It's a lot more challenging to build because now we're impacting the facility, but it does provide that secure environment that SCOC was looking for from when the clients are dropped off to when the clients are shipped out. So it meets everybody's requirements, and also it doesn't impact the facility as much as the prior version. So what does all this mean? Current state. So progress to date, as I mentioned before, we received the board approval for Consigli in November 2021. The initial target price for them was $109,925,530 with a 10% contingency of $10,992,553 for a total of $120,918,083. So the phase 1, which I mentioned, was partially you're essentially partially buying out the project. That was registered with the controller. The plan was for us to be able to lock in that price by February 11, 2022. That's when we had to change. That's when we had to pivot and redesign. As soon as we got the clearance, we negotiated a price, and we locked in the price by April 7th, 2022. So, as I mentioned again, the length of time stays the same, but there's additional time in the end because we're starting later. So the specific amendment request is the authorization to increase the consigliere contract to a total of $140,339,695. That breaks up into the GMP value of $127,581,541 plus a 10% contingency of $12,758,154. There's going to be additional, we're going to come back to the board later on because there are additional cost increases to both the consultants, the design consultant and the program consultant. But since they're working at both facilities, Bellevue and Woodhall, we're not ready to present that yet. Today, we're only ready to present consiglies. The other good news is that consigli and both consultants are doing great. They're doing a phenomenal job and they're pushing ahead with the project. The next slide shows the utilization. We're still on target to meet the 31% that was promised. The project's still being bought out, but this is a list of vendors plus their associated commitment, their respective commitments. And the last slide shows the resolution. We will take any questions.
Thank you, Oscar. Any questions from board members?
Jose?
Oh,
Sorry.
looking at the screen there, yeah.
At the screen, yeah. I expressed this at our committee meeting, and I want to express it at the board. I think it's outrageous. Oh, I got to be outraged. There, now I can be on. It's outrageous that we added $20 million to the project and have a 4-month delay just because the state commission feels that these people should be treated as if they were lepers or something and isolated from the population. We already have inmates that get transported to Bellevue. They have a system that is in place and that has worked. You incorporated that system when you did the original design. So I think it's most unfortunate that the project has been delayed. I'm glad to hear that it's going very well.
Thank you, Sally. Any questions or comments from board members?
I think we might have discussed this, but I'm curious, Oscar, if also the delay and the recontracting of the GMP, given what's going on with costs everywhere, also, do you think have you experienced some of the increases there as well, or is it just simply the change in scope?
I have experienced global supply chain issues across the portfolio, but for this particular one, I would say it was just the scope itself. It's very complicated change, simply from upgrading and modernizing what was already out there as far as outdoor space on top of the H building to something completely different over the ED and penetrating the ED, but putting in footings and foundations. So it is going to be a high impact to be able to implement this. So I would expect a very high cost to coordinate all this work.
Okay, so really is a scope change that SCOC is requiring, driving the increase. Okay, thank you.
Thank you. Any other questions? Okay, so let me then move for a vote. Dr. Katz?
Yes.
Dr. Calamia?
Yes.
Dr. Martone?
Yes.
Dr. McRae?
Yes.
Gary Jenkins? Erin Kelly?
Yes.
Robert Nolan?
Yes.
Frida Wang?
Yes.
Sally Hernandez Piñero?
Yes.
Anita Kawatra?
Yes.
And Jose Pagan, yes. Thank you so much, Oscar. So let me go back then to the item number 2 in your agenda, which it's the same resolution, but it has been amended in terms of the total amount. So let me read it for the record, the amended resolution. It's authorizing New York City Health and Hospitals Corporation to negotiate an extension of its affiliation agreement with the State University of New York Health Science Center at Brooklyn, Downstate Health Sciences University, for services at NYC Health and Hospitals Kings County and NYC Health and Hospitals Coney Island through December 31st, 2023. The total not to exceed $12,221,174, which includes a 10% contingency. I think we had discussion on it, unless there are any other questions that I'll ask for a vote. Okay, so let me then ask for a vote. Dr. Katz?
Yes.
Dr. Calamia?
Could you just explain, I'm sorry, what I see on the screen
Yeah.
is the 11,110,000. That's with the 10% contingency
No,
included?
sorry about that,
No.
and we were just discussing that. I
So-
think that was that's without the 10% contingency, because this was meant to just say
Right.
expected costs.
Okay, so let's just make sure in the resolution we're saying that there's a 10% contingency above this, and then I'm fine with voting yes on that.
Yeah, in the actual
It does
words
say
of the
that.
resolution, it does say that.
Yeah.
Yeah.
Just not to exceed $12,221,174, which includes a 10% contingency.
Okay.
Okay. So you voted yes, right? Yeah. Thank you. Dr. Martone?
Yes.
Dr. McCray?
Yes.
Gary Jenkins? Erin Kelly?
Yes.
Robert Nolan?
Yes.
Frida Wang?
Yes.
Sally Hernandez Piñero?
Yes.
Anita Kawatra?
Yes.
And Jose Pagani, yes. So thank you so much. So let's move now. I think it's the president's report, Dr. Katz.
Yes, thank you, Chair Pagan. I'm not going to read the report, although there are a lot of things that are important, and so I want to hit on them. Start by something too recent for today's report, which is the report from DOH, MH, our sister department, that there are now 19 cases of Legionella in the Highbridge neighborhood in Bronx. It's been traced to several water towers in the Bronx area. The water towers are being disinfected. People should watch for flu-like illness, cough, fever, difficulty breathing. Turns out that is not always COVID. That can also be Legionella, which is yet another, the fact that these things are happening simultaneously makes it difficult. The right answer is to seek medical care. And so we want people who have those symptoms to seek care. Legionella is a treatable illness. On COVID, what's most important for people to know is that we've been recommending that the major focus be on hospitalization rather than number of cases, because so many people have mild cases of COVID, not everyone, but many people do. And also there is home testing, which is harder than to track number of cases. But in saying we should track hospitalizations, you then may look at hospitalizations and say, oh, hospitalizations are really going up. But what's actually going on is that we test everybody on the way into the hospital. So what happens is basically our hospital mirrors the community transmission. And as community transmission goes up, the number of people in our hospital with COVID goes up, even though they're not necessarily in the hospital because of COVID. So what we're experiencing now is larger numbers of patients in the hospital with COVID. But especially when we looked at who was there in the intensive care unit, our numbers are still very low. They're in the teens for number of people in intensive care unit, keeping in mind that our peak we had 2,700 people with COVID in the intensive care unit. Now we usually most days 16, 14, 15, 18. But when we actually look at why are they in the hospital, it's not because of COVID for more than about a fourth of them. So 3/4 of them are in the hospital because in the intensive care unit because of their underlying conditions, and they just got tested as part of being as coming to the hospital. So the important message is the pandemic hasn't gone away, is not likely to go away. Home testing now plays a much bigger role, and we have tests now at all New York City schools, libraries, cultural institutions, and 850 partners. And we will keep making sure that there are enough tests for people. All of you would have seen the horrific events that occurred in Texas. Unbelievable that we can be a country where anyone can get a gun, even if they're just past 18, and go into a school and kill so many young children. The public community recognizes that gun violence is a public health epidemic. And I know there are complicated legal issues around rights to guns, but at some point it seems to me that the public health has to triumph. I mean, the loss of so many children in a single episode, as well as adults, is horrific. We have a possible monkeypox case in New York City. And because of the respect that is granted to Bellevue for dealing with unusual infections, Bellevue is giving an FDA-approved monkeypox vaccine to cases who were at high risk for the exposure. The good thing about monkeypox from a point of view of public health is it does not appear to be transmitted nearly as easily as COVID, requires prolonged exposure, probably helped by skin to skin or saliva to saliva contact. Bad thing about monkeypox, long incubation period. That's a problem because it means that you can expose many people prior to yourself having symptoms. Very challenging to control pandemics if you don't jump on them right away. We await the final Roe versus Wade decision, but have been very clear that not only will New York continue to provide safe legal abortion services to all New Yorkers. We consider this part of health care. To us, this is a health care issue. We respond to it as a health care issue, but we're also preparing to provide the same service to people from other parts of the country where abortion may not be available to them. And we're working with community partners on how that might go in terms of transportation or other facilitative services that women may need to reach New York, and then we will provide the services. We recognize 24 outstanding physicians at health and hospitals. We have done several new programs to improve our obstetrics care and care to newborn children, including a new doula program at Elmhurst in Queens that we're particularly proud of. I want to highlight the transition of the Office of Facilities Development. We were very sad to lose Christine Flaherty, who's done such a tremendous job for us as the Senior Vice President. She got a great job at a health system very close to her home that needs a lot of capital improvements. We're going to miss her, but I'm very pleased at how we're going to replace her. We have a strong belief in promoting people who do excellent job, and we have 3 people at the office who, under Christine's mentorship, have just been phenomenal, and we have asked the 3 of them to form the leadership group ongoing for the Office of Facilities Development. Manny Saiz will be the director of the office, and he'll report directly to me, as Christine did. Oscar Gonzalez will be the deputy director of the office and the director for capital development, and Menji Indar will be the chief operating officer for the office. And based on the amazing job they've done in the past, I feel certain that they will continue to develop the office and meet our needs for facilities and capital. I've asked Matt Siegler to serve as their executive sponsor. And we also want to appreciate the amazing work that Leora Jontif has done in housing as well as real estate. She's going to join Matt's organizations while continuing to work closely with the office. They had their trial by fire the very first day that Christine was gone. There was a flood at Harlem, and that could have been exceedingly dangerous for maintaining our operations, and they did a phenomenal job containing it right away. So they proved themselves on day one. A little out of my practice, I want to close with a story about my clinic yesterday, because in the big things that we do at health and hospitals, I think we can sometimes forget what an amazing institution it is and its tradition. So I was seeing yesterday a monolingual Spanish speaker. Like any primary care doctor, I see patients in 20-minute visits, and my job is to cover both their whatever illnesses they have, whatever preventive care they have, answer their questions, challenging in 20 minutes. The patient who was coming to see me, who had a number of issues, I also wanted to give her the shingles vaccine. So I thought, well, I know in order to be more efficient, so she's also an informed person, I'll print out the CDC information sheet on the shingles vaccine in Spanish, so that I can be sure that she will have it. And I arranged, very time efficiently, like a administrative doctor I am, I printed it out, gave it to her to read while I was doing other things, right, taking care of other patients, so that when I brought her in, she would know whether or not she wanted it. So I brought her in then, and we did the other part of the business. And I said, did you read the information I gave you about the shingles vaccine? And she said, yes. I said, so can I go ahead and give it to you? And I could tell immediately from her face that something was wrong. I said, are you frightened of getting it? She said, no. The sheet says that you have to have insurance in order to pay for the shingles vaccine because it's expensive. And I don't have any insurance, right? I had not actually read the whole part of the CDC. I mean, I was printing out from the CDC, right? I mean, and of course, in most parts of the country, that's a true statement, right? In most parts of the country, shingles vaccine is expensive. You can't get the shingles vaccine if you don't have insurance. Most people are not going to have the $200 to pay for a shingles vaccine. So it was an opportunity to say to her, it's okay. Everything in the center, whether it's your medicines or your x-rays or your visit, you don't need to pay for, you don't need insurance. That's why we're here. She was an NYC Care patient, and I could see that from the label, and that's undoubtedly how she came, to get her care, which based on her illnesses, she very much needs. But I thought it was such a great reminder of how different health and hospitals is than what the CDC is putting out information for everybody, which is, you want a shingles vaccine, you're going to need insurance. But not at health and hospitals. She left with her vaccine. Thank you very much, Mr. Chair.
Thank you, Dr. Katz.
I have a question.
Oh, I'm sorry. Colicia reminds me, excuse me, Sally, that I need to read this. I want to summarize one continuing agreement to policy I approved for the Street Health Outreach and Wellness Show program during the last COVID-19 surge. In July 2021, I reported having approved an exception to policy amendment for 9 months with rapid, reliable testing. This was for 6 mobile vans to be used on behalf of New York City for testing and vaccination and other needed medical assessments and treatments specifically for New York City's unsheltered homeless population. Given the success with these outreach services and the continuation of the pandemic, I subsequently authorized a 4-month extension of the program through June 2022. The program now includes 8 vans with 2 of the vans dedicated to Mayor Adams' subway safety plan and are located at end-of-the-line subway stations that are key components of that plan. The other 6 units are located at intersections selected in concert with the Department of Homeless Services due to the large number of unsheltered homeless in need of our services at those locations. Initial show agreement was for not to exceed $9 million. The additional agreement is for not to exceed $7.5 million. The cost of these services is covered by the city, while most of the staff provided by the vendor are W-2 employees, and the vendor owns the vans being used. Approximately 10% of their spend has been with diverse vendors and continues through this period. Sorry, I was required to read that. I had forgotten. Thank you, Felicia.
Sally Hernandez Piñero.
Yeah, I just have a question. Our GYN services are in high demand, and there's a lot of time pressure to get the services when abortion services are involved. So I'm wondering oh, damn, I'm not gonna start again. I'll just ask.
I understand.
Yeah, between our existing client population and an influx from other states, how are we going to manage both of those?
Well, I'll turn to our chief medical officer, who, of course, is an obstetrician gynecologist.
By the way, so we have formed a task force. There have been some conversations that have started already, and we'll be coming up with a plan. Our desire is to accept all comers, no matter what state they come from. We're working with Margie Carlin because, of course, if you don't live in New York State, you don't qualify for Medicaid, getting a lot of support from them. And we currently have the capacity, but we are establishing a task force to come up with a concrete plan, Sally, and we'll be glad to keep you up to date with how that comes along.
Okay, I appreciate that. Thank you so much.
Thank you. Go ahead.
Hello, I have a question.
Yes, Dr. Matron, go ahead.
Thank you. Thank you for your report, Dr. Katz. I just wanted to say that I'm so happy to hear that we have a plan to try to really help out women that are stuck in predicaments that are really life-changing decisions and choices. I just wanted to know, and I just heard Dr. Allen, I think it was Dr. Allen, say that we have a task force for this now. How much are we focusing on and how much money are we putting behind or planning to put behind the safety of the providers and the staff that will be involved in this? Looking at all the recent shootings and everything, we know we have individuals who could be rather aggressive when they feel things that are happening are not of their opinion. And we've experienced this in the past, and today it's just getting worse. So what are our plans to help make sure that we are really protective of our staff and providers?
Sure. Well, I'll start. We heard the same thing that you did, Dr. Martone, and we have now increased security around all of the areas where we provide women reproductive services for exactly that reason. We recognize that there is a risk to our providers, and that requires increased security. We are also more broadly looking at using the new form of metal detectors like we're using at Jacoby, which are not like the traditional ones. These allow crowds to walk all the way through and just flag if somebody has a large weapon, because we realize that these are dangerous times and we have to protect our staff and our patients.
And we've been collaborating. I see Deb just walked in. We've been collaborating with City Hall, DOH, MH. We actually are a member of the National Abortion Federation. So we're not alone here in New York. Deb, do you?
No, sorry, thanks. And Dr. Marthon, just
Thank you.
Reference to that question in particular, as Dr. Allen just said, we are partnering, getting information from the National Abortion Access Group so that our security people will be, up to speed with the best possible protocols.
And we're also training and expanding the number of providers who can perform terminations, not just provide medical terminations using advanced practice providers. We have several midwives who've been recently trained as well, just preparing for what may come down the pike in June from the Supreme Court. I do have one thing I
Yes,
want to add.
please, go ahead.
I don't know if there are any more questions on this topic.
You may. Any other questions on this topic? Okay, go ahead.
So for National Doctors Day, for our Doctors Day, someone said, why don't we ask Dr. Fauci to come talk to us? And I said, that would never happen. And Dr. Katz said, well, give it a try. So we reached out to Dr. Fauci, and of course we got the form response, but then 48 hours later got a very personal response, and this is it. This is his response. Well, we're missing the sound.
We'll get it in a minute. Hold on.
I guess we could provide a transcript to, I'm sorry, I don't.
One more try.
Come on, Dr. Fauci.
How about the closed captions?
Okay, well.
And the thing about the comment, it's really particularly.
Warm greetings and profound thanks for all you have. Dr. Allen, Dr. Katz, and colleagues, I send you warm greetings and profound thanks for all you have done and continue to do in confronting the deadliest pandemic in our lifetimes. My name is Tony Fauci, and as the director of the National Institute of Allergy and Infectious Diseases at NIH and the chief medical advisor to President Biden, and as a practicing physician, it is a great privilege to speak to and recognize all of you in New York City health and hospitals for your dedication and your heroic work. I would like to share with you some remembrances of other heroic doctors and medical providers facing a pandemic almost too terrible to imagine. One said, quote, "The acts of heroism of some of our doctors will never be known. The devotion to duty while those nearest and dearest to them were dying was worthy of an epic I am unable to write." One doctor, whose two brothers died the same day, said she would be willing to die if she were able to save the mother of 8 children who had aborted and had pneumonia. Another lost a brother, another a fiance. End of quote. These are not the words of a pandemic blogger, but of Dr. Mary Buchanan, the physician who was treating patients during the 1918 influenza pandemic. She and her contemporaries compared the tidal wave of sick and dying patients to the ongoing World War I. A colleague adding, quote, "It was truly like the rush of the wounded from the field of battle," unquote. 104 years later, many of you have been called on to face a tragically similar challenge, the COVID-19 pandemic. And you have faced that challenge bravely, nobly, with skill, courage, and with honor. Many of you gave your utmost, even while families and friends were ill or dying, and when exhaustion and despair was but one step away. At the epicenter of the early pandemic, a grateful nation saw that true heroes are not only those fighting in the fields of battle, but like those at New York City Health and Hospitals, also on the front lines of a deadly pandemic. I want to thank all of you for your remarkable efforts, the lives you saved, the suffering you prevented, the comfort and caring you provided, and the dignity you showed and preserved for others will never be fully known nor recognized. That is the fate of healthcare providers, to give to those in need when they are most in need, to place the lives of others before our own convenience, and to keep going as long as sirens sound and people come in hope that you will receive them. We are now in the third year of COVID-19, and we really do not know where the pandemic will ultimately go. Will it die down and become endemic? Or will it flare up in another deadly wave? Will our emergency rooms and hospitals and clinics and community outreaches become overwhelmed again? No one can say for certain when the pandemic may reappear, but you have shown the country that you will be ready. You and the many medical and health providers in New York and around the country and the world have shown us a modern version of true heroism. In closing, I thank you humbly for all you have done, and as we say to our soldiers in uniform, I say also to you, thank you for your service.
Okay, thank you so much. Any other comments or questions for Dr. Katz? Okay, so the committee reports. The committee reports were emailed to you and are in your folders for your review and submission into the record. Is there any old or new business to come before this board? Hearing none, then the board meeting is adjourned. Thank you so much.
Thank you.
Thank you, everybody.
Thank you. Thank you.
Thank you.
See everybody. Bye.
This meeting is no longer being